So coming over to my presentation, it will be covered into 5 headings. What is the pathophysiology of these calcified lesions? What is the detection on OCT, their morphology, severity, what's the score, and what are the different modalities which we can modify these calcium plaque. A small histopathology, why it becomes important if we see, it starts with all microcalcification. You have smooth muscle cells in which about 5 to 15 microns of calcified spotty calcifications can be seen, but these all are histopathological seen on dye. When these combine together in macrophages, they form a punctate calcification in which you might get about 15 microns to 1 millimeter. When they coalesce together in a necrotic area, they form a fragmented calcification reaching up to 1 millimeter in size, and they can be sometimes seen on imaging. When these sizes, they form a sheet-like formation up to 3 millimeter. It's a sheet calcification. And whenever there is breakage in these sheet, it forms a nodular calcification. So this is basically a pathophysiology how these calcified lesions progress. Why it is important for understanding these pathophysiology, if we see, these spotty calcifications are usually the initial part and they can have present in the ACS format, but we cannot see them clinically or on imaging. So when it becomes imagically significant, these if we have a spotty calcification or they develop a sheet or nodular formation, we can easily assess by OCT, or if there's very diffuse, we can see by IVUS. And why it becomes important, as the calcified lesions, they become more diffuse and they become more stable CAD, except a erupted calcified nodule, which may present as ACS. So as we all know, angiography is a very poor mode to detect calcification, so we rely on imaging. And in these imaging, if we see IVUS and OCT, OCT has an upper hand in cases of moderate lesion of calcified lesions in calcium thickness and longitudinal calcium length. But IVUS has an upper hand in if you have a deep calcium or you have a calcium below the necrotic area, which is there is an attenuation, you cannot see the calcification below it. We all know this impact of calcium. First is in optimal stent deployment. It will have a suboptimal stent expansion, device failure, or there is increased complications. Plus, in the MACE events also, if you compare the calcified lesions, they will have a poor outcomes in terms of death, MI, and TLR. So, imaging and addressing these calcified lesions becomes important. So how this imaging can help in defining the strategy in how this OCT can change the strategy. This was a light lab initiative which was present in EuroPCR, and it was found when these OCT was done, 51% change was in the strategy if you have a calcified lesion. And this was basically depending on the pre-dilatation of a compliant and non-compliant balloon, either by cutting scoring or atherectomy laser. So OCT really, pre-OCT helps in deciding the strategies. How to assess the very basic of it? We all know calcium appears low attenuated, light penetrates, we can see the tissue behind it. It's an heterogeneous area and have a clear delineated edges appears as eyelines or rocks. These calcium can be, depending on the location, can be a deep, that means it is below the fibrous thick cap. It can be superficial, that means it is just 0.5 millimeter below the attenuated lipid plaque area, or it can be a nodular, that is protruding inside the lumen. And if nodule gets erupted, formation of thrombus, it forms an erupted nodule. These all calcium can be present in the same patient on these morphology. And when we see these eruptive calcified nodules is a challenging nodule part of calcium which has to be dealt with. And a small, very good study of autopsy study which was done, which showed that these nodules are formed when there is a bend in the artery. So in patients who are elderly, diabetic, CKD, and they are having associated heavy calcification, whenever there is a site of mechanical stress, specifically RCA in mid area or LAD proximal area, these eruptive nodules causes ACS in these patients. What about the calcium thickness? OCT obviously has an hand over it and can get a better thickness of the calcium. We can also see whether the calcium is eccentric or concentric and what is the length of the calcium. So it gives a 3D picture of the calcium. But how this calcium morphology impacts the treatment strategy becomes the question. So this was a score which was found by, it's a retrospective study by Dr. Akiko Mehra group, and they analyzed when these patients were depending on the different morphology in these cases, they found a score in which included an angle more than 180, thickness of 0.5, and length of more than 5 millimeter. They found that these patients had more chances of developing stent under expansion. So they said if the score is 2 or less than 3, the expansion they achieved was more than 90%. But if the score was more than 4, the expansion was achieved just 68%. So they're having a more score below the under expansion of stent. The score on based of OCT was formed. How these plaque modification, that means if a score is high, we need some plaque modification in the form of calcium fracture in the adjunctive devices at high calcium score. So is there any relationship between the different strategies which we can use? Yes, there is. If we found that was a study which was done in patients of undergoing rotablation and followed by balloon angioplasty in these cases, they found that if the calcium arc is more than 270 degree and the thickness is less than 0.67, these patients respond better to your rotational atherectomy followed by balloon angioplasty. So they found that ROC curve of cutoff of 227 and 0.67 thickness, and they labeled that you have to achieve a thickness of less than 0.6 millimeter to show that the balloon expansion is better. So larger calcium arc and thinner calcium thickness were associated with a better formation of the cracks in these cases. But there are certain challenges whenever we go for these rotational atherectomy in these cases. First, the presence of eccentric calcium is not very indicated. Ratio of the minimal lumen area with the burst size will cause having a differential cutting will be difficult, or a guide wire bias may be a challenge in case of patient undergoing rotational atherectomy. So ideal scenario, these patients should undergo whenever the calcium arc is more than 270 or the lumen size is less than the burst size is become important. So there are different modalities which are available. First, either you can go for a balloon-based techniques in these cases in the form of they basically do a cracks in the calcium which increase the plaque elasticity. So these in the form of cutting balloon, scoring balloon, or intravascular lithotripsy balloon. Or we can go for a ablation techniques in these cases. This is in the form of either rotational atherectomy or orbital atherectomy. Excimer laser, not a very good technique for calcified, more for a fibrocalcific lesions in these cases. So how to approach? I think my next talk by our next speaker will be of plaque modification, but if we see the algorithm, if we can form by OCT, if we are able to cross the balloon or the OCT catheter, we have to first see the morphology in these cases. If it's a deep calcium, this deep calcium, then a cutting balloon or a scoring balloon or sometimes IVL will be helpful in these cases to do it. If you are having a superficial calcium, then we have to assess the score. If the score is less than 1 to 3, then these strategies of cutting and scoring balloon will be helpful in our cases. But if a score is more than 4, then we have to do some plaque modification in the form of atherectomy or IVL. If you are getting a good calcified arc more than 270, the lumen area is less than the burst size, then ablation therapy would be an ideal choice in these cases. But if you are getting an eccentric calcium, the OCT catheter is away from the calcified part, there is wire bias and MLA is more than burr part, then IVL will come as a savior in these cases. After doing these cases, always we should try to see whether we are able to produce any fracture in these cases or not, then a OCT should be done. If you are having a good fracture or MLA is less, fracture is not there, we should go for these, again, the balloon strategies in these cases. Go for the cutting balloon or a scoring balloon, if needed, IVL. Good expansion in 2 orthogonal views after balloon dilatation and we are having a good MLA, then we should go for a deployment of the stent. If still not available, then again try to do these strategies. After deployment, we should look for post-stent expansion. Like in the morning also we were having a discussion, sometimes post-stent expansion is under expansion. Still under expanded, go for OPNNC or IVL. In uncrossable lesion, again the same started with ablation therapy and the same flow chart will follow. For the nodule part, still a very controversial thing, either go for IVL, rotational, and I've kept it for the next speaker, Dr. Mahesh, he can give highlight on the nodule part. 2 limitations for OCT, deep calcium cannot be seen and calcium below the necrotic plaques is a challenge in these cases. This was a study which was done, autopsy study, they found OFI, and they found that the patients who were having a lipid cornea below it, they won't be able to see the calcium in these cases. A small case, this was a simple case of anterior wall MI having a LAD was stenosis. I did the balloon dilatation, but didn't get any good result. There was not much significant calcium in this case. But to my surprise, when I did the OCT in these cases, there was a calcium, plus in the proximal part, there was a nodular protrusion of the calcium, which did allow my balloon to dilate. So this was a nodule which was protruding inside it, which was not angiographically very clearly visible in these cases. Did a IVL and got a good result of good post-stent expansion of 80%. So in concluding my summary, imaging is helpful in assessment of calcium, either the type of or what is the severity in guiding the appropriate therapy for optimize the stent expansion. Lesion preparation is must prior to any stent implantation in these cases. There are different modalities present depending on the calcium severity. No modality is better than the other. They go hand by hand, and they have to be used in adjunctive therapies. And planning of calcified lesions by imaging either OCT or IVUS is a must. Thank you.